Yeah, thank you. For those who don't know me, I'm Paul Anderson. I'm one of the orthopedic surgeons here at the University of Wisconsin, and I've been past chair of the AOA Own the Bone Committee, so very interested in fracture liaison service, secondary fracture prevention. And I want to introduce our second speaker, Dr. Andrew Cozadd, who's a physician's assistant. Andrew works in Minneapolis at Health Partners with a variety of different orthopedic organizations in the Twin Cities, and he runs their fracture liaison service. And he's been a real leader in the field in trying to teach both MDs as well as the APPs in how to set up and run fracture liaison services. I think his talk is very interesting. It's one thing to start up a fracture liaison service, but it's actually even more difficult to maintain it and keep it going. So I hope Andrew will give us some good tips on this.
Well, thanks for the kind introduction, Dr. Anderson, and thanks for the invitation to present on this topic. It's great to be here with everybody tonight. As you know from the introduction, there's nothing particularly interesting or impressive with my resume, but I have been involved with an FLS and a bone health clinic for the better part of the last decade. That started off in private ortho practice, which really kind of proved to be just a case study in humility, where we tried for a number of years to get an FLS off the ground, but it was a single man effort, and there were many struggles along the way. But we did have some success, and I learned a lot of valuable lessons along the way that hopefully I can help others not repeat. And since then, over the last 3 years or so, I've moved over to an integrated health system at TRIA Orthopedics, and with a pretty strong amount of administrative support, we've been able to really push forward a successful FLS program. So with that, hopefully I'm able to give you a few pearls on establishing and maintaining an FLS clinic. I've included my contact information. I know that there's going to be really limited time for questions at the end of this. So if you have any questions, or if you just want to make a connection, certainly feel free to shoot me an email, and I'm happy to connect that way. I don't have any relevant disclosures. I am part of the AOA Own the Bone Steering Committee. It's a group of us kind of from around the country that kind of grapple with FLS related issues and how to best incorporate these and implement them and maintain them in orthopedic settings, whether it's university or private orthopedic practice or integrated health systems like the one that I'm in right now. So this is my overly ambitious list of topics that I hope to cover over the next 20 minutes. First, we're going to start with an overview of the osteoporosis treatment gap. I think most people on the call probably recognize that osteoporotic fractures are common. It's not uncommon for our patients to slip through the cracks, not receive screening, and not receive any treatment after that injury. We'll define a fracture liaison service and how that might help to close that treatment gap, discuss some of the steps involved in developing an FLS. I'll kind of lift the veil and show you what we do to try to target our inpatient fractures, as well as target some of our outpatient fragility fractures, and how we move them kind of from point A, which would be the time of fracture, to point B, which is ultimately getting them into my bone health clinic so that we can screen and treat for osteoporosis. And last, but certainly not least in the eyes of administration, we have an overview of the financial considerations of a bone health clinic. Long term, for any clinic to be sustainable and successful, it has to be financially sustainable as well. So there's a few key considerations there as well. So here's our clinical scenario. This is our 72-year-old patient who falls, and unfortunately she breaks her hip. There's lots that we do well in our health system, and there's some things that we somewhat struggle with. And I think this is kind of representative of what takes place in hospital systems all across the country. So following her injury, she is taken by EMS to the hospital, and her perioperative care is excellent. So we are very good at managing acute injuries. So she has all the latest and greatest when it comes to orthopedic care. She has surgery within the first 24 hours. She is mobilized early and often by physical therapy after this. She has DVT prophylaxis, delirium, decubitus ulcer prevention. And, after a couple days stay in the hospital, she goes to a transitional care where she continues with her physical therapy. And ultimately, she's discharged home. And, her overall level of function takes one step back. You can tell from the picture that she got around with a cane prior to the injury. And, afterwards, while she was still at home and while she was still independent, she primarily used a walker for ambulation. But, 6 months down the road, she was doing quite well. And so here in the orthopedic department, we're kind of patting ourselves on the back so hard we give ourselves a bruise because we feel pretty good about this outcome. But there was one glaring thing that was missed, and that was the fact that nobody told her that this injury met clinical criteria for the diagnosis of osteoporosis, and that she was high risk for fracture. The data varies from one study to the next, but somewhere between probably 15 and 20% of hip fracture patients go on to sustain a second fracture in the first year after that injury. And unfortunately, that's what happened to her. So a year out, she fractures again, and this time her outcome isn't nearly as good. Ends up in a care facility long term. She's never able to be independent like she was before, and she kind of saw that downward spiral in her function afterwards. And so we need to not just be good about managing acute injuries, but we need to look at long-term prevention as well. I wish I could say that was kind of the exception to the rule, but unfortunately it's not. When we look at osteoporosis screening following some of our quintessential osteoporotic fractures, so compression fractures in the spine and hip fractures, our screening and treatment rates are really, really poor. Barton et al., this was a study that was published in 2018, pretty comprehensive. They looked at nearly 3,000 consecutive patients that presented to a single healthcare system with a compression fracture. And they followed those patients for a number of years. And what they found was that in the first year following the injury, only 2% of patients had a DEXA scan. And in that same first year, it seems like 5% were started on a bisphosphonate or some sort of treatment. So it seems like some providers were empirically starting them, which is perfectly appropriate and within our guidelines, given the fact these compression fractures carry such a high risk for subsequent fracture. But still, it's probably 95% of patients that could potentially be high risk that had no screening and no treatment. I think even more damning is they followed these patients for 2 years, and what they found was that within that 2-year interval, nearly 40% of them went on to have a second fracture. And so that just highlights that treatment gap that exists. We need to have a little bit more pep in our step as we're seeing these fractures come through our healthcare system. I didn't include the study, but that same group implemented an FLS. And while their screening and treatment wasn't, 100%, and I don't remember the exact data, but I think over 50% of patients were ultimately screened and treated after they implemented an FLS. So it just shows sort of the power that an FLS can have in bridging that treatment gap. Hip fractures, we do a little bit better, but still a lot to be desired. In the first year following a hip fracture, probably 20 to 25% of patients will have a DEXA and ultimately get on treatment. It's a pretty data heavy slide. I include it more for your reference than anything else. But what we know is that fractures beget fractures. Once a patient falls and their bones prove that they can break, their risk of a subsequent fracture goes up significantly. It varies based on the bone that's broken, but when we lump all fractures together, and this is a database that's looking at Medicare patients, particularly women 65 and older, in the first year following an incident fracture, nearly 10% of patients go on to break another bone. And within 5 years, that number jumps to over 30%. So clearly, again, following an incident fracture, we need to have osteoporosis in the back of our minds, and we need to come up with some sort of a system to encourage osteoporosis screening and treatment. Fractures don't just increase your risk of fractures, and not all fractures, lead to a full recovery. One thing that we find is that fractures have significant morbidity associated with them. Some patients never make a functional recovery. Some patients have chronic pain. Some patients are institutionalized, and some patients are then, unable to participate in social outings and things that otherwise would bring them joy. There's a lot of depression as well. But not only that, but fractures can be associated with an increased mortality risk as well. The one that gets highlighted the most, and I think the one that is sort of on the forefront of our mind, is a hip fracture. In the first year following a hip fracture, nearly 20% of patients will ultimately die. But it's not just hip fractures. When you look at some of the data on compression fractures in the spine, pelvis, humerus fractures, even forearm fractures, when you follow patients out a few years or even a year out, there is a significant increase in mortality risk. And so if we're trying to optimize long-term care for our patients, fracture risk reduction certainly needs to be a part of that. So this is where we can insert an FLS. I think we basically have two choices. One is we can leave it to individual providers within the healthcare system to just happen to recognize osteoporosis and encourage referrals and encourage treatment, or we could come up with a system that is multidisciplinary and tries to standardize the conversation around osteoporosis care from the get-go. So the goals of an FLS are just that. We're going to identify fragility fractured patients at the time of their injury. We're going to counsel that patient in the teachable moment. To anybody that treats osteoporosis, when we get patients that are, say, 65 and they haven't fractured yet, and they get their first DEXA that shows osteoporosis, osteoporosis is a chronic asymptomatic disease. It doesn't necessarily cause any symptoms. And so when you tell somebody that they have fragile bones and that they're likely to fracture in the future or have an increased likelihood, there's this huge disconnect between the numbers that they see on the paper and how they feel. And so patients aren't necessarily motivated to seek treatment at that point. But if we counsel them in that treatable moment right after a fracture, patients are kind of in the throes of what an osteoporotic fracture is all about, and they're very motivated and they're very receptive to that conversation because they certainly don't want to go through that experience again. So it's a great time to talk to patients. We're going to initiate some sort of coordinated multidisciplinary care, and we're going to make it routine. So instead of calling on individual providers within a healthcare system to happen to recognize osteoporosis, we're going to make it standardized from the start. The end outcome is we're going to improve patient care and we're going to decrease liability on the healthcare system. It's not common, but there have been some case studies where orthopedic surgeons have been successfully sued because a patient had a fracture. There was no conversation about osteoporosis and they ended up having a second fracture. And so if nothing else, CYA goes a long way when it comes to motivating people to do the right thing as well. So I think the first several slides here kind of highlight the osteoporosis treatment gap, highlights how an FLS system could be helpful in closing that treatment gap and encouraging osteoporotic screening and treatment. So how do you go about developing an FLS? I think the first thing is you need to kind of rally the troops and figure out who's going to be your bone health champion. This could be the person that treats osteoporosis within the health system, but it doesn't have to be. Ideally, this is going to be someone in a leadership position in the orthopedic department. And I was really fortunate in my current role where we have two powerhouse trauma surgeons. We have Dr. Julie Schweitzer and Dr. Mark Swinkowski, who are very motivated to take on this role and have really helped propel the clinic forward. So I think the role of the bone health champion is they're going to help kind of develop that care pathway, figure out how we'll get patients from point A to point B, and what's going to work best within the health system based on the resources that are available. They're sort of influential in taking the idea to administration and kind of pitching the idea and gaining support there. And then they can also help communicate individual roles of other stakeholders that'll be involved in the clinic as well. So once you identify your bone health champion, and once you figure out who's going to be actually treating the osteoporosis, whether that's going to be a dedicated bone health clinic, whether these are going to be referrals to primary care or some other medical specialty that'll manage it, you've got to get prepared because now you have to pitch the idea to your administration and you may only get one shot. So in a perfect world, and this isn't available to everybody, and it certainly takes a little bit of effort, you would gather some current data on the osteoporosis treatment gap that exists within your own health system. So if you're able to mine some data from Epic and pull some ICD-10 codes for different fracture types, and then do that look ahead to see who had a DEXA following and who was put on treatment afterwards. If you can show that there's a gap that exists and it's in your own health system, I think that hits home when you're talking to your administration. But certainly that takes time and that might take some resources. And if you don't have that time to put together your own data, you could certainly use data from the previous slides and kind of show that this is a common problem throughout the country and there's no reason to believe that the data is any better at your own facility. So the goal there is, again, highlight that treatment gap that exists within your own health system. If you have access to it, it's also really helpful to come up with a few individualized stories and something that might pull on the heartstrings and hit close to home. So if you can pull up some x-rays of a couple patients that have fractured, and the gnarlier the better. If they have a bunch of plates and screws and pins and cables, it's pretty eye-opening when you see those types of injuries on the screen. And then if you can gather like a patient testimonial where the patient describes the experience and how traumatic it was. And maybe the family talks about how traumatic it was on the family and how great of a burden it was as this patient transitioned from their fracture to transitional care and coordinating all their post-op care and things like that. Again, it's pretty easy to convince administration that this is the right thing to do. But long term, like I said, if you're going to have a sustainable program, you need to make sure that's going to be financially sustainable. So as you're pitching this and as you're pulling on the heartstrings and showing the data, it's also helpful to come up with a plan to say, you know, in the first year, this is what we're going to do. These are the patients that we're going to target. And then over time, we're going to scale this up and, you know, look to bring in additional patients to the clinic. And over time, you know, based on the different things that can generate revenue, whether it's consults or whether it's injectable medications or other things like that, how you're going to make that profitable. So this is how we do it in our health system. And of course, this is geared towards what works for us. There are easy ways to kind of adapt this to your own healthcare system. And I'll kind of mention some of those as well. So on the inpatient side of things, we see a number of hip fractures and pelvic fractures and other fractures that get admitted to the hospital. We're fortunate to have sort of two main trauma hospitals, and we have a couple of APPs that more or less live on the orthopedic unit. And so they do all of the inpatient rounding, and they do the vast majority of our inpatient consults as well. So they're sort of uniquely positioned to see all of these patients. And so usually on post-op day 1 or post-op day 2, say after a hip fracture, they'll actually do an inpatient bone health consult. So they'll have a conversation with the patient explaining that their fracture places them at high risk for osteoporosis, and that as part of their follow-up care, not only should we focus on healing from this injury, but we should do everything that we can to minimize their risk of a second injury. Our current guidelines for screening are all patients that are 50 and older that come in with a low energy fracture. We started with hip fractures, and once we came down with sort of this streamlined approach, we expanded the criteria to include other fracture types as well. Then what they do is they place sort of inpatient labs for the typical labs that you would expect. So metabolic panel, vitamin D, things like that. We'll correct vitamin D deficiencies, start patients on supplements as needed. We'll place the order for the outpatient DEXA, as well as to the outpatient bone health clinic, which I run. What we tried to do initially was to create one parallel track, more or less. So they would see their orthopedic surgical team for their post-op care, and they would see me for osteoporosis care. What we found is that, particularly for hip fracture patients, you know, so many of these patients are ending up in a nursing home where it's so challenging to get them from the nursing home to the outpatient clinic that a lot of times the bone health clinic appointment was just falling off. So our overall capture rate wasn't very good. We found that if we combine their 6-week post-op care for their orthopedic care with the bone health consults into a single visit, we capture probably over 75% of those patients in the outpatient clinic. So we now have a captive audience to talk about osteoporosis, review their bone density scan, review their labs, make sure they're on appropriate treatment, and then we communicate any treatment changes to their primary care team. And so again, that was something that we had to adapt over time, but ultimately we made it successful by combining. I know of a lot of other clinics, orthopedic clinics, that have been able to keep them separate and found ways to make that successful as well. And in the day and age of virtual appointments, you can certainly do a phone or even a virtual appointment for bone health with the patient as well at their care facility, and that's been successful too. So say you don't have a freestanding bone health clinic, where else can you send your patients to? You can certainly send them to primary care. So the same thing can happen on the inpatient side. You can have someone round on them. You can do an inpatient consult for osteoporosis care, put in all the right discharge orders, but just send a note over their primary care saying, as part of your, discharge follow-up, we should probably include osteoporosis care. If you have rheumatology or endocrinology that tends to manage osteoporosis, you can certainly refer to them as well. Or if you can't convince administration to hire, say, a single person to run a bone health clinic, because obviously that takes significant funds, maybe you have somebody in the orthopedic department that isn't ready to dedicate their entire practice to osteoporosis care, but maybe they're willing to, dedicate a half day of clinic to managing a bone health clinic. And maybe you start small. Maybe you start with hip fractures and a few select fracture types. And over time, you can kind of expand the criteria. And after you sort of prove proof of concept, And that person can decide if they want to expand their bone health practice, or maybe now it's easier to justify hiring somebody once you have patients that are embedded within that bone health clinic. On the outpatient side of things, it's really not too different. But of course, we don't have a few APPs that are sort of the sole providers of all outpatient fracture care. And so we've kind of created 3 different nets to try to capture as many patients as possible. The first is, when I came on, we had this pretty aggressive education pitch to our different care teams to try to encourage referrals of their low trauma fractures. So in the outpatient setting, these tend to be your 50 and older wrist fractures and proximal humerus and pelvic fractures and others. Of course, that'll capture a certain percentage of patients, but in a busy orthopedic practice, a lot of people are still going to slip through the cracks. So then we created this bone health questionnaire. Essentially, any patient that's 50 and older, when rooming staff brings them back to their room, a couple questions will pop up for them. And one will say, have you had a fracture, 50 and older? Have you been diagnosed with osteoporosis, and are you on treatment? If they've had a fracture and if they've been diagnosed with osteoporosis, but they're not on treatment, there's kind of a soft stop in our EMR that encourages them to refer to the bone health clinic. It pre-populates the order set that makes it very convenient, which includes the DEXA, the labs, and the referral. And the patient can then opt in or opt out. Not all of our care teams use it. The ones that do find it very helpful. Unfortunately, if you don't use it, of course, it won't work. So that would include or lead us to bucket 3. And bucket 3 is kind of the last ditch effort to get a hold of these patients. And we haven't fully incorporated this yet, but if you have Epic or if you have an EMR system, it's quite easy to mine some data and create sort of this work list where pulling ICD-10 codes, you can take a 6-month look back and find all the different fractures that have come through your health system. And you can pre-select, say women that are 65 and older with a fracture, and then you can send them a message via MyChart, or you can send them a letter in the mail saying, because of the injury that you had, we recommend a bone density scan, and this is how you can coordinate that follow-up care. So again, starting at the provider level and then trying to have a couple automated, nets to catch the rest of the patients that fall through the cracks. Quickly, you can capture a good majority of those fractured patients that come through your clinic. So again, these are referred using that smart set that we have. They're brought to my clinic. And again, we have that dedicated osteoporosis consult, review their imaging, review their labs, and initiate treatment. Again, it doesn't have to go to a bone health clinic. These are patients that can go to primary care. It can go to endocrinology or rheumatology. It can go to a very limited clinic in the orthopedic setting. And so you just have to figure out what's going to work best for your clinic. So how do you go about growing your bone health clinic? We've primarily focused on outpatient fractures and inpatient fractures. But when you take a look around an orthopedic office, there's a lot of patients that would potentially benefit from a bone health consult and have compromised bone health. And so I see a number of patients that have fracture non-unions. I'll see a number of patients with recurrent bone stress injuries. I think the most classic example of this would be your young female athlete that has a female athlete triad. And more we're finding that pre-surgical optimization, so screening patients for osteoporosis prior to joint arthroplasty or prior to spine fusion, can improve both early and long-term surgical outcomes if you place those patients on treatment that are high risk. And last but not least, how do you make it profitable? I think first you just have to understand what's going to be billable and what's not. And so the billable events are inpatient consults. You probably can't bill on the date of admission, the date of surgery, or the date of discharge. But if you have a hip fracture that comes to the hospital, that leaves probably post-op day 1, 2, and 3 that you can see the patient and bill for an osteoporosis consult. Certainly outpatient consults are billable events. You'll have long-term follow-up care. So osteoporosis is a slightly different business model than the typical orthopedic clinic. In orthopedics, we see a lot of acute injuries where the goal is to kind of treat them and street them. And so they'll come back if they have another injury, but the goal is to get them past their injury and then hopefully not see them for quite a while. Where osteoporosis is a chronic disease, it's going to require some sort of long-term follow-up care, whether they're on medication or not. And so bone health clinics have a way of sort of snowballing on themselves as more and more patients are referred to the clinic, and those follow-up patients continue to come back as well. So those are the ones that are easiest to document. But as you create a bone health clinic in an FLS, you're going to be ordering more labs as you're screening for osteoporosis and secondary causes and contraindications to treatment. You're going to be ordering more imaging with DEXA and opportunistic CT and things like that. Osteoporosis medications, particularly the injectables, so zoledronic acid, romosozumab, denosumab, these don't necessarily have a huge profit margin, but just based on the sheer volume of patients that may be on these medications, that small margin can certainly add up over time and help to justify your bone health clinic. And then referrals to physical therapy, maybe using a dietitian or a nutritionist and others. So as you sort of bring this to your administration, or as you're documenting the billing associated with the clinic and the revenue generated from the clinic, these are the buckets that you should look at, certainly. And so that's kind of a whirlwind overview of fracture liaison services. Hopefully there's a few pearls that you can take from that, and appreciate your attention. Thanks.
Well, thank you very much, Andrew. I think you made some very good points that are good take-home messages for our audiences. I think one of the questions is, how do you differentiate billing for fracture care, whereas the surgeon may be billing for fracture care during the global period, whereas you're billing for osteoporosis care? And if you're in the orthopedic clinic, are there any concerns about both of you billing? Let's say you see this patient on the same day.
Yeah, and so we've had this conversation with our billing department, and from my understanding, there isn't a concern. What you do is you would add a 24 modifier to your billing code. Essentially, that says that you're seeing the patient in the global window, but you're seeing them for something other than their direct fracture care. In osteoporosis, while it contributed to their fracture, it is considered outside of that global. So by adding that modifier, you can bill both on the inpatient and the outpatient side if you're within that first 3 months following the fracture. It's a good question.
Yeah, thank you for
that
that.
is a great question. If you start to get compliance officers involved, like we have at the University of Wisconsin, you can get adverse opinions, which really hurts the finances of your program. Anybody else want to ask any questions?
I just wanted to mention that I have been adding the modifier 24, and I've still kind of come across a lot of problems with billing, so I am fighting that right now.
There may be good news on that front in the future. The BHOF, the Bone Health and Osteoporosis Foundation, the ASBMR, along with some orthopedic organizations, have proposed to CMS a bundled care package for global care for secondary fracture prevention, which would avoid all of these issues and probably increase reimbursement 30 to 40% compared to what's done currently. So if that's accepted, I think that will solve a lot of the financial problems of these programs. Allison asked a question about treatment initiation by APPs in your clinic. So Andrew, you have no problem yourself being an APP writing prescriptions for anabolics, let's say?
Yeah, I think my comfort level has kind of changed over time. When I first started to dabble in the osteoporosis world, at first I primarily limited myself to bisphosphonates and then referred everything else on. And then over time, as you find a mentor or two and you become more comfortable, then right now, because it's the entirety of what I do, I feel comfortable managing even some of the most complex of osteoporotic patients. So whether it's anabolics, whether it's patients with multiple comorbidities, whether it's difficulty with transitioning therapies over time, I think the key is to find a good mentor within your healthcare system and then just grow your comfort over time.
Okay. Thank you very much.